talking to them. Let me know if you want more.
All right, you guys can hear me okay? All right. Welcome, everybody. Thank you very much for joining us here for this session entitled Translating Research to Advocacy and Public Policy, a case study of pediatric mental health. We're going to do the introduction of our speakers in a little bit, but just wanted to kind of start with a little bit of background that most of you guys already know about pediatric mental health, that both the number and the complexity of mental and behavioral health complaints by children continues to increase by quite a bit, and the COVID pandemic actually exacerbated this even further. Some of the reasons behind this increase simply might be because there's more going on, because social media is influencing a lot of it. Some of it is also increased awareness of early symptoms of mental and behavioral health, and because of that, there's a lot more referrals now happening by families, by schools, by primary care offices, and at the same time, there's been a reduction in the capacity of the system to care for pediatric behavioral mental health. So we're having less psychiatrists on board. As a matter of fact, we are anywhere 1 in 124,000 children. There's one psychiatrist for 124,000 children. And that is at least 5-fold less than what the minimum requirement is. So we definitely don't have enough psychiatrists. We don't have places for children to go. A lot of the state institutions closed down many years ago. And this causes us in the ED as a safety net to be the de facto referral center for all of these patients. And obviously, we don't have the resources, we don't have the staffing, we don't have the space to take care of this massive surge of pediatric mental health patients for a variety of reasons. And that is what the boarding process of keeping children in the emergency department for long periods of time, for initial assessment, for collecting collaterals, for making disposition decision. So this is a multifactorial problem that needs a multifactorial solution. We always talk about how one of the things we really need is better legislature, better policies. And to do that, we need to be in the earshot of those people who make the policies and make the legislature. So part of this talk really focuses on the fact that we need to generate some really good evidence-based, solid research that provide us amazing data. We can then take this data and show it to all those people who make policy and show them why this is urgent, why this is so important. For example, we know if your hospital has a pediatric emergency care coordinator or a pediatric champion, somebody who will advance the cause of children, that has been shown directly to affect better health outcomes and better preparedness of that hospital. So we know some research already is helping drive policy, but we're not doing enough, essentially. So the objectives of this session are threefold. The first is to discuss the importance of not just doing a research so you can get a publication out of it, but doing a research that is purposeful, that is actually aimed to improve processes for children's healthcare, and therefore the eyes of the policymakers. So specifically, you make a research study so that it can reach wide audiences, can be marketable to policymakers. And then you also want your research to really be based on the best evidence possible so that when you have data, that data actually can be showed, bar graphs, charts, easy for people to digest. But then in doing that, the third objective is talking about the challenges that you're going to run into if you're trying to get into the more political element of research, which is policy and advocacy. So I am acting as the moderator for this session. My name is Mohsen Saidinejad. I'm a pediatric emergency medicine faculty at Harbor-UCLA in Los Angeles, and my academic appointment is at the UCLA David Geffen School of Medicine. I locally also serve as the director for the Institute for Health Services and Outcomes Research at the Lundquist Institute that is attached to my hospital. I'm a researcher and advocate, mostly in mental health, and I've been around for a long time. And with me, I have a distinguished panel of 4 of my friends and colleagues, each of whom will bring their unique perspective into this discussion. So we're going to have them each kind of talk about work that they've been actively involved with, starting with Dr. Ashley Foster, who's a new faculty at the University of California, San Francisco. Her passion is pediatric mental health, pediatric readiness in mental health, and the pediatric emergency care coordinators and their role in improving care of children. And then Dr. Jennifer Hoffmann, who's a faculty at the Feinberg School of Medicine at Northwestern and in the Division of Pediatric Emergency Medicine at Lurie Children's in Chicago. Her area of interest including mental health, but mostly with equity and access to healthcare, as well as surrounding suicidality and including work that she's done with firearm safety. And so she's a big star in this field, and she's an amazing researcher. Dr. Lois Lee, good old friend of mine from Boston Children's. She's an associate professor of pediatrics and emergency medicine at Harvard University and in the Division of Emergency Medicine at Harvard. What is your current, you're a faculty advisor, a senior faculty advisor, right, in the equity and diversity? Yeah.
We also have the new Founding Institute for Pediatric Health Equity, which is more outward-facing, and I'm one of the associate director for public policy.
Correct. And she's a great advocate. For many, many years, she's been involved with the American Academy of Pediatrics, has written and led the authorship of many policy statements related to pediatric mental health and, again, with injury prevention. So great to have her with us. And finally, Dr. Christian Pulcini, who's a faculty at the University of Vermont in Burlingame, Vermont, and his area of interest and focus is on infants and children with medical complexity, as well as special needs children. And she's also very involved in research to advocacy. So I'm very excited to be joined by this amazing group of faculty. So our talk is going to be 3 segments. First, Dr. Foster and Dr. Hoffmann are going to talk about the way you generate data for the purpose of showing the advocacy kind of elements of it and to get people excited about the work that we're doing, understanding the needs of the policymakers, and also share data with them. And then Dr. Pulcini will talk about partnering directly with those who make decisions when we're designing our research so they understand the work that we're involved in and the space that we occupy. And finally, Dr. Lois Lee is going to talk about leveraging our own clinical experiences and our research expertise to influence the advocacy and policy element. So with that, I'm going to start with Dr. Foster. I'm going to give that to you.
Great. I better speak into the microphone. Thanks so much, Mo. I'm going to kick us off by sharing a little bit about my research. That the project was titled Comprehensiveness of State Mental Health Legislation and Perceived Access to Mental Health Care for Children. And to give you all a little bit of context in terms of how this idea was developed, myself and the senior author, Dr. Amanda Stewart, really hope to understand and aim to investigate how laws could potentially impact care for children. Mo already gave an excellent introduction about pediatric mental and behavioral health crisis that's going on in the US, but I'll expand a bit more to provide context for my research. 1 in 5 children in the US have a mental or behavioral health condition, and as Mo already identified, accessing necessary treatment can be really challenging, as an estimated 50 to 70% of this population do not receive care from a mental health professional. Although a shortage of pediatric mental health providers in the US is a driver to limited care, inadequate insurance coverage also contributes to decreased access to care. And parity law can aim to ensure mental and behavioral health care are covered at the same level as all other conditions. Several federal laws have passed that focus on creating parity standards. However, gaps remain related to types of mental health conditions covered, as well as enforcement of laws by state insurance regulators and Medicaid programs. State-specific mental health insurance laws can build upon federal laws and allow for strengthening and enforcement of these laws. However, the type and quantity of the laws may differ state by state. So to better describe the comprehensiveness of state private insurance laws, Megan Douglas Esquire, who is a co-author on this project, developed an insurance laws data set based on 4 themes of comprehensiveness: parity, mandated coverage, mental health condition definition, and enforcement and compliance. Based on an assessment of the laws in each state, a comprehensiveness score was determined, with a potential score ranging from 0, or least comprehensive, to 7, or most comprehensive. For the remainder of my portion of the panel, I will use the term state insurance laws to keep it a little more brief. The displayed map showed on my left here shows that there's ongoing variability in insurance law comprehensiveness by state as of 2020. So what Dr. Stewart and I did is we actually approached Megan Douglas to pair with her and collaborate and pair the comprehensiveness score with the National Survey of Children's Health, which the National Survey of Children's Health is a cross-sectional survey with nationally representative sample of community-dwelling children ages 0 to 17 years in the U.S. And since 2016, the survey has been administered annually by the U.S. Census Bureau. Parents and caregivers answer questions on behalf of one child chosen within sampled households. So we aim to understand, because little is understood about comprehensiveness of state mental health insurance laws and how it may impact access to care for children with mental and behavioral health conditions, we linked the pooled data of the National Survey of Children's Health to the state insurance law scores. Using this combined data, we aim to describe the relationship between the comprehensiveness of state insurance laws and the perceived access to mental and behavioral health care, as well as the perceived adequacy of insurance coverage for mental and behavioral care in the U.S. To do this, we conducted a retrospective cross-sectional study using state insurance law scores and the National Survey of Children's Health from 2016 to 2019. The score children ages 6 to 17 years of age with a mental or behavioral health condition were included. As our primary predictor, we defined comprehensiveness of mental health insurance laws using this state insurance law score. And again, going from 0 or least comprehensive to 7 or most comprehensive. And scores were grouped into lowest, second, third, and highest. The first outcome measure was poor access to mental and behavioral health care, and this was defined by the survey question to my left, with answer responses of big problem, very difficult, and it was not possible to obtain care. The second outcome measure was inadequate mental and behavioral health insurance coverage, defined by the question below, with answer responses sometimes or never. We described the dataset scores and the 2 outcome variables by state and then performed a simple cross-tabulation of the predictor and outcome variables using chi-square analysis for categorical variables. We then used multivariable regression models to analyze associations between the state insurance law score and the perceived poor access to care and inadequate insurance and adjusted for patient-level variables. And all of this was conducted within the context of survey design characteristics of the National Survey of Children's Health to generate population-level estimates. All estimates were reported as odds ratios with 95% confidence intervals. What we found is interesting. The mean state insurance law score was 3.5 with a range from 0 to 7. This figure shows perceived poor access to mental and behavioral health care as it relates to the state insurance law score. The coloring of the orange from light orange to dark orange represents the percentage of respondents within the state who report poor access to mental and behavioral care. The perceived poor access ranged from 5.96% to 17.52%. The text numbers within each state represent the state insurance law score. For example, Florida has a state insurance law score of 2, and the darker orange shade represents that 17.52% of the survey respondents identified poor access to mental and behavioral care. This next figure shows the outcome of perceived inadequate mental health insurance coverage and the state insurance law score. The mean state insurance law score was 3.5 with a range from 0 to 7. The coloring of purple from light purple to dark purple represents the percentage of respondents within the state who reported inadequate mental and behavioral health insurance coverage, which ranges from 5.78% in South Dakota to 17.54% in Nevada. The text numbers, again, within each state represent that state insurance law score. What we found when we performed the analysis is that children in states with the highest category of state insurance law score, or that score of 5, 6, or 7, or most comprehensive, had lower odds of perceived poor access to mental and behavioral health care, with an adjusted odds ratio of 0.79. Children in the third highest score category, with a score of 4, had an increased odds of perceived inadequate mental and behavioral health insurance access, with an adjusted odds ratio of 1.23. So where do we go next from this? Just to summarize again what we found, the state insurance law's score that was most comprehensive score of 5, 6, or 7 had a 21% lower odds of perceived poor access to mental and behavioral health care. This data supports advocacy for fully comprehensive state mental and behavioral health insurance legislation to allow for appropriate access for children with these conditions. Although the finding of increased odds of perceived inadequate insurance coverage for the third highest insurance law score, or score of 4, was surprising to us, there may be a common thread or missing elements of policy for mental health within the states with a score of 4. So we're really excited to take the next step and conduct further analysis by state to better understand if there is a common thread among themes missing in the groups with a score of 4, or the states that are in the score of 4. Additionally, we aim to further describe perceived access and insurance outcomes by specific pediatric mental and behavioral health conditions to understand if specific medical conditions are less or more impacted by this variability in comprehensiveness of legislation. We believe these findings and future study with the state insurance law score will allow for better understanding of the relationship between access to care or access to insurance and strength of state-specific mental health insurance legislation, which in turn can allow for targeted advocacy within each state. With that, I will now turn it over to Jen.
Hi everyone, I'm Jen Hoffmann from Lurie Children's. So Dr. Foster provided an excellent example of the kind of analysis you can do that's very policy relevant. And I'm also going to share a study that I did that has policy implications. And I'll present the study itself, but then I also want to discuss the second step, which is disseminating the results to policymakers and to the media. So as background, we know that mental health professional workforce shortages are widespread in the United States, and they also vary geographically. So child psychiatrists are less likely to practice in rural and in high poverty areas of the United States. This map shows my home state of Illinois, and you can see that the counties in gray, which are mostly rural areas, have 0 practicing child and adolescent psychiatrists. So this got me thinking, what's the impact having of these workforce shortages on youth mental health? And in particular, what's the worst mental health outcome? That's suicide. So we know that suicide is the 3rd leading cause of death among US adolescents, and suicides also vary geographically. Youth are more likely to die by suicide in both rural and high poverty areas of the US. But the independent association between mental health professional workforce shortages and youth suicides had not been previously explored. I was interested in this because it's a potentially modifiable variable as opposed to a county's rural-urban status, which can't be changed through policy. So the objective of this study was to determine the association between mental health professional workforce shortages and youth suicide rates in the US at the county level after adjusting for county demographic and socioeconomic characteristics. We conducted a retrospective cross-sectional study including all US counties and all suicide deaths by youth 5 to 19 years old over a 2-year period before the pandemic. This was the most recent year that data was available for the 2 data sets utilized at the county level, CDC death certificate data and the area health resource file. We chose as a marker of workforce shortages the federal designation of a county as a health professional shortage area, or HPSA. This is a policy relevant variable because it's tied to funding for workforce development programs. In addition to the binary designation of whether or not a county had workforce shortages, there's also a score from 1 to 25 that indicates the degree of workforce shortages in the county relative to the need. And we constructed models that adjusted for other factors like socioeconomics, virality, demographic composition, and year. So this map shows the distribution of just over 5,000 youth suicides across the US, with counties in darker red being those with higher youth suicide rates. This map shows in dark blue counties that are designated by the federal government as having significant workforce shortages of mental health professionals. And across the 2 years studied, 2/3 of all US counties were shortage areas. And then finally, this third map shows the score, indicating the degree of mental health professional workforce shortages, where counties in darker blue are those with higher degrees of workforce shortages. This bar graph shows our unadjusted results. So on the x-axis, you can see the score indicating the county mental health professional shortage area score, which represents the degree of workforce shortages, where a higher number indicates greater shortages. And on the y-axis, you can see the annual suicide rate per 100,000 youth, which increased in a stepwise fashion as the degree of workforce shortages increased. When we performed our adjusted models, we found that mental health workforce shortage designation, or HPSA designation, was associated with 1.16 times higher the youth suicide rate, as well as 1.27 times higher the youth firearm suicide rate specifically. We found that the adjusted youth suicide rate increased by 4% for every 1 point increase in the county mental health HPSA score, indicating more workforce shortages. So these findings have a number of policy implications, which I wrote about in the discussion of my manuscript. Most directly, they indicate the need for increased workforce development programs to build a more robust pediatric mental health workforce, which includes not only child psychiatrists, but also developing primary care pediatricians to be more prepared to care for youth with mental health needs. And these are funded by a number of grants through HRSA, the U.S. Health Resources and Services Administration. This also supports the need for funding for graduate medical education programs, which receive their appropriations from Congress, such as the CHGME program, again, to better prepare general pediatricians to care for mental health needs. In addition, these findings suggest the need for increased funding for pediatric mental health care access programs. These are telehealth-based programs that connect general pediatricians to child psychiatrists for consultation on cases that are going on in their own office. And again, they're funded by the federal government. Medicaid reimbursement rates need to be increased for mental health services to support and retain the mental health workforce. Also, funding for telehealth access needs to be streamlined and improved with elimination of regulatory barriers to reach children in areas where there aren't any mental health professionals. And then finally, permanent CHIP authorization, the Children's Health Insurance Program, would allow all children to be able to access needed mental health services by providing them with the insurance coverage that they need to do so. So after writing about each of these aspects in the discussion of my manuscript, I started with disseminating via the traditional route, which is via a scientific manuscript. So this work was published in JAMA Pediatrics in November of last fall, and it was accompanied by a podcast by the editors, which helps to disseminate to a little bit of a wider audience. There was an accompanying editorial written by Dr. Erin Carroll, which had a catchy title, "The U.S. Mental Health System is So Broken That Even Money Can't Fix It." And this was widely read and circulated. And since the time that I created this slide, a letter to the editor was submitted from a representative of SAMHSA, the U.S. Substance Abuse and Mental Health Services Administration, which noted a need for increased funding to improve the mental health workforce to address these problems. Also, I worked very deliberately to disseminate these findings through the media. And the way I did so was by working with my hospital's public relations department in advance of the date when the publication came out. So I worked with the professionals in my hospital to prepare a press release, which was disseminated to reporters locally and nationally. And that allowed them to learn about my study and contact me for interviews, either by phone or by television. And as a result, they were able to prepare their own articles to be released to align with the same date that my article was published in JAMA Pediatrics. And that gives them the hook that they need for the work to be timely. So this led to articles in U.S. News and World Report, some online publications that are primarily facing medical professionals like Medscape and Helio. You can see the image there was a televised interview on local news. And I was most excited about the publication in The Hill because this is a media publication read by folks who make health policy in DC. And as an indication of the reach of this article in terms of the media, there's a score called the altmetric score, which you may have seen next to some titles of publications online. It looks like a rainbow donut, and the various pieces indicate how many times the research has been picked up by the news as well as through blogs and social media. So this article scored an altmetric score of 486, which was in the top 5%. Which is also something that you can include on your CV when you're talking about the impact of your work. Additionally, my hospital's PR department was able to pull some statistics about the reach and found that the article was written about in 338 unique media placements, reaching an audience of about 90 million viewers with an ad value equivalency of around $800,000. So unfortunately, I wasn't able to benefit from any of that ad revenue, but at least it shows the degree of impact that this kind of work can have. And now I'll turn it over to my colleague, Dr. Christian Pulcini.
It's hard to follow that. My work is not worth that much. So, all right, thank you guys for having me. It's really interesting because from their data that they showed, I was honing specifically in Vermont, where I'm from, and it actually gives the appearance that we're doing really well, but I promise, like, we are not. And that's kind of sad, right? Because we're scoring the highest on some of these and we're reporting higher access. But one of the things, and the reason I mention that is because the thing that led me to get involved in this space, Mo mentioned that my actual primary research focus is on children with medical complexity in their emergency care, was out of sheer need. I showed up in Vermont in a general emergency department and I saw kids boarding next to adults for days, weeks at a time. And I just, considering the injustice of it all, was like, something has to be done about this issue. And I can't just go through this every day and not try to do something about it actively. So as a researcher, I was like, what the heck can I do? Luckily, I did some advocacy training and had some great mentorship throughout all of my training and had talked to legislators before. But just to give you some background about Vermont, it's primarily a rural population, as probably many of you know. I say single children's hospital because it's not a freestanding children's hospital. It's within a larger, the only academic medical center in the state. We have a single inpatient mental health facility that is not connected to the university at all. It is a private institution that I can't remember how many beds it has. Do you guys remember? It's only like 8 or 10. I mean, it is like very small number for the entire state of Vermont, and that's the only place that the kids can go. Sometimes they get sent to one of our affiliate hospitals in New York, but there's very limited space for inpatient psychiatric, the level of inpatient psychiatric care. There are only 13 EDs in the whole state, and 5 of them are critical access. All of these EDs, because I've done this research, except for our own, has less than 5,000 pediatric ED visits per year, and at any given time in the year that I did this study, they had at least 1 or 2 kids boarding in the emergency department. Some of them have 4 ED beds, and one of them was a child that was boarding in the ED. So because of this and because of me knowing this, I wanted to know what are the gaps in understanding? Like, why aren't we doing something about this on a more state level, policy level? So what happened was I voiced my opinion in several different places. I started to get into some of these circles of people that were having these discussions, because it is obviously a concern of the public. It's a concern of a lot of different groups around in Vermont. And so they asked me to go and testify for the Vermont House Healthcare Committee. And so that was my first time really getting involved. And I said, I'm going to use this and try to figure out what exactly are the gaps in understanding in this problem and how can I best serve these kids who are in the emergency department every day. So I testified to the House Healthcare Committee, and really interestingly, you would think that some of these questions would surprise me, but from doing advocacy before, I think my first experience doing advocacy, I was a medical student, and I was so nervous to go talk to a legislator. And it was about lead poisoning. And I had all these statistics, I had these stories about lead poisoning, and I get to the end and the legislator's like, wait. Is lead really that bad for kids? And like, that was the question that came out. So I wasn't really terribly surprised with some of the questions that were thrown at me about this issue, but it is really amazing from your lived experience every day how much you can add and how much questions you can answer that they may have. So these are some of the questions that they have. Why can't you give them something to do in the ED? And I've calmly responded, yeah, I can give them something to do for 1, 2, 3, 4 hours. It's really hard to give them something to do for 3 weeks. And they didn't really know how to respond to that. There was an awkward silence. But then and our ED doc's able to offer therapeutic intervention. So they didn't understand the milieu of the emergency department and also our training. And so I had to explain how I was trained and what I was trained in. Also the fact that the kids don't stop coming to the emergency department. Like there are other patients that you have to see, and that's just how the milieu is and the culture of the ED. And then this was a really interesting question. Do the kids really truly need to be somewhere like the ED, or are they just throwing fits? And like, I couldn't really, I said no, it's actually severe, these are severe mental health conditions that need inpatient psychiatric treatment, and we only have one facility in the state. That's the reason why they're staying. It is certainly not because they're throwing fits, but I didn't have any data to like prove any of this. And so what I did is I took their questions and I said, I'm gonna answer them. So luckily I received support to do research by other stuff. And so I just get to do what I want sometimes. And this was one thing that I was very passionate about. This is like the thing that kept me up at night. So I went and did a qualitative study of families' experiences. So we went and interviewed families and said, what are your experiences in boarding in the emergency department? And that is under review. That has been by permission shared with some of the legislators, and they're not sharing that beyond that. There are ways to get around those sort of embargoes for these policy relevant things for certain journals, just so you know. And then also I got all of the EDs. This is everyone knows it's such a problem. There's only 14 luckily in Vermont. I got all of the EDs to do chart reviews of kids who were boarding in their EDs and collected like demographic information, how long they were boarding, what they were boarding for, were restraints used, so on and so forth. A lot of different variables. And that was published in Academic Emergency Medicine last year. And so I went back to the legislature at that point and presented this. No, they're not throwing fits. 78% of them are coming in with suicidality, and the other around 20% is aggression, usually honestly in the younger age group. But I had clear data from all of the emergency departments in all of Vermont to then filter back to them. And then this New England EMSC collaborative was the New England EMSC developed these activity kits for kids for something to do while in the emergency room, and as well as activity binders that could benefit kids while in the emergency department. And so I went out and found a grant through the Vermont Community Foundation and got it funded for every single ED in all of Vermont. So at least I felt like I was doing something while they were there. And then we're still collecting data about the utility of those kits. Those are publicly available, by the way. And I can't tell you, but we did collect data just from the quality leaders. That again is actually under review from Academic Emergency Medicine as one of those research briefs, because it was just a brief survey. So, but like this is the whole premise of this is like research into action. So for media, I followed up with a media piece and wrote it to the Vermont Digger, which is well read by a lot of Vermont legislators. It's probably the most well read piece, the most well read media outlet in Vermont that received some press, and some legislators actually reached out to me to talk to me about this. The legislative I already talked about. Leadership is getting up and standing up, like when you see an injustice, standing up, and if you do have, especially if you have data, to get up and actually volunteer to speak to legislators and let them know about your experience. And then mentorship, and below me is somebody who did an EMSC fellowship who was interested in mental health, and she got to do the qualitative study that I referenced before, is also mentoring others who are passionate about this. And there's going to be a medical student this summer who's actually going to be working on addressing adolescent needs while adolescents are boarding in our ED as something she self-identifies what she wants to do. And then the piece to the right, hundreds of suicidal teens sleep in emergency rooms every night. If you didn't see that piece in the New York Times by like an award-winning author that is there, it was actually Dr. Lee, who's I'm gonna pass it over to very soon, who was interacting quite a bit with this, with the author, who was going around children's hospitals and interviewing about the boarding and mental health crisis, and Dr. Lee actually said, hey, there's this guy Christian in Vermont, and he has some data on there's kids in rural and critical access hospitals that are boarding there with no pediatric services whatsoever. You might want to talk to him. So it was really funny because he almost had the whole entire piece written. He's like, I had no idea that kids were boarding outside of children's hospitals. And so he added on a little piece with that study that I had done before about that kids were boarding on average 4 days in these critical access EDs in Vermont. So that was an interesting experience. Also, the New York Times obviously catches the eye of some legislators, especially when it's multiple pieces like that. And with that, I'm going to pass it over to Dr. Lee.
All right, so I'm going to just start talking a little bit about this technical report and policy statement. So what do you do, right, with this data? And what we're good at these different professional societies is trying to put them together. So how many people here belong to ACEP? All right, good. Anybody belong to AAP? Oh, good. We're paying lots of professional dues, aren't we? Anybody, any nurses? Anybody here in ENA? No. Oh, excellent. Okay. Do you, well, are you an ENA as well? Yes. And so this is truly a partnership, right? Because we, as the physicians, are certainly not taking care of these mental patients who are boarding in the emergency department. We all know it's the nurses who are really spending so much time, really, taking care of the daily needs as well as helping with the mental health care needs. So this was a joint, I'll say, labor of love. I mean, that might be kind of facetious, as Mo would know, between the AAP, the ACEP, and ENA in drafting this technical report and policy statement called the Management of Children and Youth with Pediatric Mental and Behavioral Health Emergencies. And then actually Dr. Sue Duffy is leading the effort for a clinical report, which is just an AAP document. This is not, it's still going through final review, and hopefully will get published later this year, but really to provide a resource. The technical reports, like the literature, and then the policy statement is the recommended policy, so I'll just be going over that. And we broke it down, right? We know that it doesn't just start in the emergency department. It starts with all these kids in the community, and that really thinking about the pre-hospital folks who take care of these patients is important. That was not a focus for us, obviously, because there's other venues for that care, but we need to acknowledge that. So we kind of broke it down to pre-hospital and emergency care and community care when we thought about what policies we wanted to recommend. And I think one of the things COVID helped us realize is that we actually can do telehealth, we can bill for telehealth, and that actually does allow for better access for subspecialty needs that otherwise kids, especially in rural places or even in urban places, right, might not have access. So we recommend expanding those telehealth services, and now with the end of the end of the sort of public health emergency, all these rules around billing and access and interstate, right, licensing are changing, and so that's like something we really need to stand up and advocate for now, because obviously that's not just helping with mental health, right? That's helping with health on a broader level as well. Focusing on mental health mobile crisis teams, really trying to step away from law enforcement being involved. Now, sometimes law enforcement does need to be involved, but then they should be trained and we should be partnering, right? And because sometimes de-escalation and then referral to the appropriate acute care treatment can happen without necessarily bringing the child to the emergency department, which, as we know, is very disruptive. But making that triage decision in the field, because sometimes bringing them to the emergency department is the right thing, right? So how can we build up this resource? And again, that's more of a challenge in rural areas and less well-resourced areas. Obviously, we need resources to provide better trauma-informed and culturally appropriate care at every level, right, for every type of clinician. And we need better standards and systems for referral networks to subspecialty care, but then also once we care for them in the emergency department setting, do we just release them back out without any help, trying to kind of build those networks. And we need to make sure that all these environments are appropriate and safe. And I think, Christian just pointed out, I think legislators have no idea being in a room with no windows, with no access to a bathroom, and perhaps your only contact being a sitter or your nurse, and occasionally, this mental health provider, that is really not care, right? And so how can we build better systems of care, even thinking about EMS transport? And then what are the best models of care while boarding? For a long time in our hospital, we didn't do anything. They literally just, stayed in the room. And then we realized as things have gotten worse through the COVID pandemic, and I think probably all of us have experienced that we actually really need to start doing something. So now we start prescribing medications. We actually started doing group therapy for appropriate, patients, initially by Zoom. I think they might be doing some of that in person. So that just sitting there, and I always give the example of, when you have a child with a new diagnosis of leukemia, you don't let them just sit there for 3 weeks and not do anything. But yet we are okay with having children in mental health crisis literally just sit there for 3 weeks, right? And we barely do anything. And then also thinking about the community and how in the emergency department, how do we engage with the community, but really advocating for more community-based behavioral services. So Massachusetts, actually, we just passed some legislation in the last few years that now we're able to stand up more of these urgent care sort of mental health facilities, not just for kids, but for adults. I don't know if others are in states where you're doing that sort of thing. Show of hands, no. There's some good models of that actually here out in California. So I think that's something, to think about. More school-based programs. We did a study actually looking at how many kids got transferred to the emergency department just for, behavioral outbursts. And basically they would come, we would feed them lunch, their parents would take off work and lose time from work, right? And then we would send them back home. They rarely needed a higher level of care. So we actually demonstrated how much money Medicaid paid to us and private insurance paid to us to basically feed them lunch and have the social worker talk to them. So imagine if you put that money back into the schools, right? How much more effective that would be, and you can de-escalate and actually provide ongoing services, not just for mental health, but also for other things like being a witness to violence or other things that might be going on in the community. Having better interfacility transfer agreements, and even just knowing, right, what beds are available in your state. I don't know, everybody's hospital works differently, but our social workers and the resource specialists are on the phone, literally calling every hospital to see, do you have a bed available? Does this insurance work? Do you have a bed, the space for this particular condition and a child this age with these comorbidities. So it seems like in 2023 we should be able to have better interfacility agreements and just a better dashboard of figuring out what's going on. And better referral networks with inclusive coverage. Again, it's terrible when you have to say to the family, well, it sort of depends on your insurance, and that sounds terrible to them, and they don't understand sometimes they do, how complicated it is, but that certainly is not a good look for the health system. And then obviously always bringing it back to the medical home. So as Dr. Hoffmann talked about, we really need to increase mental health care access by expanding the workforce. So one of the things that is now available this year through HRSA is the Pediatric Loan Subspecialty Program. And that's actually not just open to people boarded in pediatrics, but really technically anybody, which maybe the pediatricians don't want to share. It's not a lot of money, but it could be for pediatric surgeons, pediatric mental health specialists. So things like that, right, to encourage people to go into a field that we know actually is not very well compensated. More integration into primary care, and so Massachusetts, but other states now have adopted this model where the primary care pediatricians have some training so that they can do basic prescriptions for anti-anxiety medications and antidepressives, but then also have like real-time access for mental health consultation with the specialist. So again, having more of that come from the mental health provider where they can do screening, they can actually do some early treatment, and then referral and consultation as needed. And then again, can't focus enough on community-based care. And then also for the last part of the policy statement, again, research, obviously that's important. So what are sort of the emergency medicine services for children strategies to screen, identify, and connect kids in behavioral health crisis? More evidence-based guidelines for screening and assessment, as well as acute and follow-up care. And then acknowledging, right, there are huge inequities in access to care and huge disparities in outcomes. So better understanding what are things that put children at risk, both from a structural and societal level, but also at the micro, individual level, and trying to reduce these risk factors. So the future directions that we ended up with in this policy statement, which hopefully will get published this year, is that, really kind of building out quality indicators and metrics so that we can have better playing field to see how our individual hospitals and systems doing to improve and standardize care, considering ED readiness work, so that's some of the work that Dr. Foster is doing. So we know it's, very different if you're in Vermont versus if you're in an urban center in California. And so how to identify those gaps, and then how do we fill those needs, right? Developing models for evaluation and treatment and national professional standards for consultation as well. And then again, better mental health support networks, especially for acute crisis care. So now I'm going to sort of switch gears with this work that I did with the AAP, then sort of building this area of expertise. I was invited to be part of this Children's Mental Health Crisis Continuum panel being on this expert panel. And this was convened by SAMHSA as were developing a series of sort of guidelines for improving the mental health care of kids. So I'm going to talk a little bit about the development of that. And so it's called the National Guidelines for Child and Youth Behavioral Health Crisis Care. Hopefully everybody raises their hand to this question, no pressure. How many people have heard of 988? Please say everybody. Okay, so if you haven't, this is actually the Suicide and Crisis Lifeline. And so again, to emphasize, it's called a lifeline, not a crisis line. And it was instituted last summer, and it's like the 911 for mental health crisis. So it's 988, it's free, and basically doesn't matter where you are, doesn't matter if you're in the middle of Vermont, it doesn't matter if you're in the middle of Nevada or in Boston, Massachusetts, you can call this number, and there's somebody who is supposed to answer the phone 24 hours a day and try to be that lifeline, for you, or a family can call as well on behalf of somebody having a crisis. And so they're calling, it's a starting point for building this 988 crisis system that supports youth and families effectively. And it's focused on crisis care. And this guideline basically has best practices, implementation strategies, and practical guidance. And it advocates for the 3 components of a stepped care system that is effective, but it tries not to use too many resources, knowing that this is very resource restricted. And so they basically describe this youth crisis continuum. And I kind of like how they described it. The first step is someone to talk to, right? So somebody's in crisis, you call 988, or the family calls 988. And then you have someone to respond, so that there's a mobile crisis team, someone who can respond, or someone who answers the phone and then can refer you. And then if you need, a safe place to be. So someone to talk to, someone to respond, and a safe place to be. And this is focused on youth and their families. And this was all built on the core principles of safety for the child and family, but also safety for staff, on equity, trying to improve access to mental health services when you're in a time of crisis, that of course it should be trauma-informed care. They're really trying to emphasize peer support, especially for the 988 services, and then making sure that it's culturally and developmentally appropriate at all different stages. And basically no wrong door, right, to access the care that you need. So this is the ultimate goal. I think 988, that was a great first start. Trying to build up all these other services is going to take more time and resources, but now we have this sort of infrastructure in every state, no matter where you live. So hopefully that's a take home everybody can kind of leave with. And so lots of things we can advocate for. So I went through a bunch of things in the policy statement, and then some other things just to focus on, and some of these things we've touched about, right? We need to fund a diverse workforce, not just more people, right? We need to expand the diversity of the workforce, ensure insurance coverage for all youth, and so states that have not expanded Medicaid, because Medicaid's also tied to CHIP payments in many states, would be important, funding for research, and supporting anti-poverty practices, because we know there's lots of sort of structural reasons for the mental health crisis we're seeing today. Other areas for advocacy is increasing capacity for services, improving reimbursement, right, on every level for everybody. We need Medicaid funding also to bill for interpreter services, and expansion of telehealth mental health services reimbursement. So thank you guys for your interest in this topic and for your time today. And then Dr. Saidinejad is here to help us moderate any questions. And do you want me to?
Sounds good. Yeah, and I just wanted to also add to what Dr. Lee presented on the policy statement and technical report. These things take forever, and there's so many different perspectives, and the number of times we had to go back and forth to satisfy each of these organizations' way of putting certain language in there and how they would like to see it, which is opposite to the other entity, and you have to kind of juggle it. It's kind of interesting. Okay, so I see some questions in here. So first of all, before I see questions here, let's take questions from you guys. I know this is a very hot topic, controversial also about how research goes into policy and what policymakers actually listen to, but let's start with you guys.
One great presentation. You mentioned law enforcement. I'm in Florida, work with Florida EMSC, et cetera. And, we're having a huge problem with law enforcement because what they do is, parents have an argument and they just, in Florida, we call it Baker Act. And then, they're brought in, and then our mental health professionals don't want to overturn it. So they're added to the mix of those that are truly suicidal. So in your advocacy work, have you engaged with any law enforcement type groups or seen anyone doing that? 'Cause I think that's a big, I don't know if it's in other states, but that's a huge issue for us, is that's just the new way to solve a family argument, is to Baker Act them.
So we haven't specifically, but as you alluded to, we've made some national recommendations about that law enforcement. Sometimes it is appropriate, right, but that they need better training. However, then there's state laws that actually that kind of supersede what the recommendations can be. And so one of the things would be, right, to engage with state lawmakers, which in your state can be somewhat challenging.
And often it's the parent. I mean, they're really the problem, but they just immediately believe, what the parent states. Then you have to report them to Child Protective Services. So it's just kind of a vicious cycle. But anyway, it sounds like you're making some great headway.
Yeah, and it's very interesting in terms of the philosophy, again, of these different professional organizations about the involvement of law enforcement agencies. That actually was part of our paper. We had to go back and forth about under no circumstances should law enforcement be involved. That's one end of it. And the other element of it was, well, law enforcement is a necessary part of the solution. However, we require, better training, better understanding, and there's no one size fit all. So we came up with a middle ground language, but those are all part of conversations that are extremely kind of heated, and it depends on really who you talk to. So that's a really great point you brought up.
This isn't maybe directly related to the problem you stated, but we have partnered at our hospital with law enforcement to obtain gun locks for distribution to families of youth who have suicidal thoughts and whose firearm is stored unsafely. So many local law enforcement agencies will have gun locks available for distribution, and those can be distributed through healthcare organizations.
Thank you for sharing all of your experiences with us. So I guess what are the ABCs to becoming involved? So if you're a clinician or a researcher that wants to take that step in becoming an advocate or being involved in the political process, do you go through your hospital system as you did through your PR? Do you go through expert panels you might be invited to later career? Do you go through professional associations or lobbying groups? What are your experiences with that? And how would someone who's relatively young in their career make that kind of leap? Because I would have had no idea to go to the PR group at my hospital and say, hey, can you get this out before the embargo, and make those connections. And clearly it had a really big impact. So how do you learn those tools or the resources to get involved?
I would say for me, there is no one size fit all. The answer is all of the above. And, first thing is that nobody knows you, right? First thing is you say something and people say, wow, that was a brilliant thought. And somebody comes and talks to you. Then they invite you to do something. And from that, you get additional invitations. I think it's a cascading event. So as an early career person, you basically need to start trying different things and then see which one gets traction. And then you move along in that path. I'm one of the ones who's been involved with professional organizations early in my career with ASAP and AAP. And I volunteered to be on committees. And then next thing you know, they asked me, do I want a chair of the committee? And then when you have those positions, you can invite, influential people to come speak. You can reach out with a title and a purpose. So a lot of times it's easier to have something behind your back before you reach out. But there's no one way to do it, really, honestly. I'll leave others to also comment, but that was my perspective, being here a long time.
I had an interesting path where it was research, then led to, like my mentor told me to go do it, and so I just did what I was told. But then after that, I realized that after doing Teach for America, which I did before, I had a little bit of a chip on my shoulder about social justice and equity. So honestly, the first thing is like, if you're that passionate about an issue, you have to convince yourself that by standing by, you're essentially a witness to it. Yeah, get mad. Yeah, it's fine. And then I did get media training through the American Academy of Pediatrics, and I think ASAP also offers similar things, like trainings that you can go to so you have some idea. Mentorship, there's certainly people around the country who are doing this, connecting with those people who are already navigating it well. And then sometimes you got to put yourself out there. The article that I wrote in the Digger, you have to have your hospital read that, like government affairs, or else you're going to dig yourself a deep hole, which I did when I was a resident. That's a different story. But like, it was about firearms. It wasn't good. I survived. I'm here. There are multiple avenues to which you can do it. And then we have an advocacy subcommittee, like in the American Academy of Pediatrics. It's in the section of emergency medicine. So like we all get together and join people together and kind of hopefully will bolster advocacy in general in this section of emergency medicine. But that's on the AAP side. I'm not sure if you're involved in that, but there are plenty of people out there to do this.
At Lurie Children's in our PEM fellowship, we're one of few programs that has an advocacy curriculum for our fellows that we started about 3 years ago now. And it actually teaches these skills of working with the media, working with legislators, and we get content experts and potential mentors. So as part of the SAEM advocacy committee, we're hoping to spread that model to other hospitals who are interested in developing a similar program. So we'd be happy to share if anyone's interested.
And the last thing I was going to say that wasn't mentioned before is think about state chapters. So certainly state chapters at ACEP, state chapters at AP. A lot of times they are already working with legislators about something specific, and you could always go to them to talk to them about bringing an issue that you care about most. And they have really great mechanisms and relationships locally already in place that are really helpful, especially when you're early career.
All right, I think we're at time. They want to prepare the room for the next talk. So thank you everybody so much for joining us, and we really hope you enjoy the rest of SAEM and Austin.